today I am going to discuss about malignant liver lesions. Anatomically, liver is divided into two lobes, right and left, and 8 segments with completely divided vascular and biliary structures. And with this, essentially is very helpful in surgical approaches to the liver for resection of different segments or lobes, for excision of tumors and other pathologies, and also in transplantation. Now going to our main topic of liver hepatobiliary neoplasms. These are benign and malignant lesions. Benign lesions are solid and cystic, and malignant lesions are either primary or metastatic. Benign lesions, when we look at these lesions, characteristically, benign lesions with expectancy of cure is primarily our goal. And also when we look at the metastatic lesions, they're limited to, if they are limited to an anatomical region of the liver that permits their resection, with exception of expectation of increased longevity. Primary malignant tumors also are limited to anatomic regions of the liver that permits their resection with expectation of cure or increased longevity. Primary malignant tumors and rare benign lesions occurring diffusely throughout the liver, treated by total hepatectomy with liver or organ cluster transplantation, and also we do have unresectable tumors. Just to mention the benign lesions that we see as part of a differential diagnosis before we go to the malignancies. These lesions are categorized as solid lesions like hemangiomas, infantile hemangioendothelioma, liver cell adenoma, focal nodular hyperplasia, and mesenchymal hamartomas. Also, we have cysts in the liver, which are congenital cysts, and echinococcal cysts, which are divided as granulosis or hydatid cyst and multilocularis. And of course, we have liver abscesses, which again can present as a liver lesion. Now, going to our main topic of today, primary hepatic malignancies are divided primary lesions, which are divided into hepatocellular carcinoma with its variant fibrolamellar hepatocellular carcinoma, cholangiocarcinoma, hepatic epithelioid hemangioendothelioma, hepatoblastoma, and sarcomas. And of course, secondary lesions, which are most the metastatic lesions, like metastatic neuroendocrine tumors, metastatic colorectal tumors, and also metastatic lesions from breast, melanomas, lung cancer, urogenital cancers, and lymphoma, and all the rest. Just to mention a few words about what is common and what is not common. Hemangiomas are most common of all hepatic neoplasms. So we do see hemangiomas if we do scan across the board. Normal people, probably we see over 10% of these patients may do present with have hemangiomas. And most common malignant hepatic tumors are metastatic lesions. And most common primary hepatic malignancy is hepatocellular carcinoma, just to keep in mind when we look at these lesions. So primary malignancies of the liver, we start talking about hepatocellular carcinoma. Hepatocellular carcinoma is most common primary liver tumor, is the 4th most common cancer worldwide, and 2nd most common cause of cancer-related death worldwide. In this little picture, you can see that those areas in red are where the hepatocellular carcinoma are most commonly seen in population with lot higher incidence of probably more than 20 per 100,000 population. And then the areas of gray and lighter areas are less commonly seen in population. So, as is the second most common cause of cancer-related death worldwide, high incidence of in China and Africa, as we mentioned, and lower in Europe and North America. In the United States, in 2015, we had 36,000 new cases with 25,000 deaths related to hepatocellular carcinoma. And when we look at all these cases, unfortunately, only 20 to 30% are curable with liver resection or liver transplantation. And this is basically because of the late presentation, and by the time we see these tumors, they are either spread out of the liver or advanced inside the liver. So and also another main factor of being not resectable is about 90% of these cases are with cirrhosis, and that limits rate of resection in these patients. Annual incidence of hepatocellular carcinoma in cirrhotic patients is about 3 to 4%. So when we follow all these cirrhotic patients, we can see about 3 to 4% chance of cancer. And in fair number of countries, when there is a patient with cirrhosis, they follow these patients on a regular basis with ultrasound, CT scan, or alpha-fetoprotein with the hope to detect these tumors in earlier stages, so when they have more chance of cure. As I mentioned, the patient is more common in patients with hepatitis C and hepatitis B virus infection. Hepatitis C virus patients, when they have hepatocellular carcinoma, almost all of them are cirrhotic. And hepatitis B patients, on the other hand, the cirrhosis is not needed for hepatocellular carcinoma to sit on liver with hepatitis B, and these patients are probably better candidates for liver resection if the tumor is limited to certain parts of the liver. And also, we do have inherited diseases of the liver like hemochromatosis, alpha-1 antitrypsin deficiency, glycogen storage disease, and tyrosinemia, which have high risk for developing hepatocellular carcinoma, and to a lower percentage in Wilson disease. These days, we see a outbreak and epidemic of NASH, non-alcoholic steatohepatitis, and cirrhosis due to fatty liver, which also increases risk of hepatocellular carcinoma. And we do see more and more patients with hepatocellular carcinoma in this group of cirrhotic patients that they come to us, at least for transplantation. It's more common in male population and also in advanced stages, 30 to 60 years of age. To diagnose hepatocellular carcinoma, if a patient comes in, of course, it's just like any other disease. We follow history of the patient, if there is any liver disease, history of jaundice and alcohol use, history of hepatitis or IV drug abuse or things like that to indicate as its risk factor for hepatitis B and C. And then physical exam, we definitely would like to look at if the patient is jaundiced, has ascites, or evidence of end-stage liver disease or cirrhosis is present in these patients. And laboratory values are, CBC is helpful to see what is the platelet count and white cell count, which is usually in cases of portal hypertension due to cirrhosis, platelet count is low, and that can give us a hint that there should be high portal pressure because of cirrhosis. Liver function test abnormalities, we do see a higher INR in these patients and prothrombin time. We do hepatitis panel to find out if there is patient is infected with any of those risk factors of hepatitis B and C, and then alpha fetoprotein is another parameter that we do check. Not all patients with hepatocellular carcinoma show high alpha fetoprotein, but it's a relatively sensitive and specific test, but we have to have really high numbers. Patients with hepatitis C tend to have higher alpha fetoprotein, even without hepatocellular carcinoma. But if anything more than 400 is significant for presence of hepatocellular carcinoma, and also we are looking at new markers of the disease for earlier diagnosis. So with the diagnostic workup, we do have conflicting reports for screening, like as I mentioned, alpha fetoprotein and ultrasound or CT scan every 12 months. In certain countries, like Asian countries, they think that is cost effective and beneficial to detect these tumors in earlier stage, and they call it as effective as colonoscopy. In Western countries, because the incidence is lower, probably this is not a cost-effective method to follow these patients. And also the other parameter that we need to watch is a variation in tumor doubling time, which and the biology of the tumor, which some of these tumors grow really fast and some not. And we have to follow these patients on a per case basis. Probably the best modality of making a diagnosis of hepatocellular carcinoma, other than biopsy that we'll discuss about it, is CT scan or MRI. And for CT scan, we definitely need a triple phase CT scan, which shows late arterial phase, venous phase, and delayed portal phase. And the reason for this is that this is a plain CT scan without any contrast that we pretty much is hard to appreciate a tumor, maybe a shadow here, maybe a shadow here or here, but we really don't know if any of these are tumor or not. However, when we do inject contrast in arterial phase, we see early enhancement of these lesions, which is common in several different benign and malignant categories. However, when we see rapid washout of these contrast in the portal venous phase, that is more or less pathognomic for hepatocellular carcinoma, and then you can see that in equilibrium, we don't see the contrast anymore, but we do see a pseudo capsule around the liver, which again is suggestive of hepatocellular carcinoma. So based on this, most centers do not do liver biopsy if they see the picture like this, and even United Network for Organ Sharing for indication for listing a patient for liver transplant for hepatocellular carcinoma, they do not require liver biopsy, and based on CT scan, we can list the patient for transplantation. So we talked about CT scan and all the necessary phases that we talked about, then chest CT, and also just to rule out malignancy, metastatic lesions, and also what is also important in these studies is the appearance of the lesion, and number of lesions that we see, because these are all prognostically different. Vascular invasion by the lesion, directly relationship to the vascular structures. If the tumor has invaded any of the blood vessels in the liver, that makes it very major risk factor for the tumor, and a very high rate of risk for recurrence. And also appearance of the liver, whether the liver looks cirrhotic or not. So these are all the parameters that we do see in a good CT or MRI. So this is again another patient with in the arterial phase. You see some blushing of the tumor, which is multifocal, and which is pathognomic for hepatocellular carcinoma when you see the contrast has disappeared in venous phase. So based on what we already discussed, prognostic factors are tumor size, if it's less than 5 centimeter or more than 5 centimeters, or if there are number of tumors are important. We discuss about it a little more. And vascular invasion, histologic grading. Of course, this probably happens if we do the resection or do transplant and we have a piece of liver out. Pre-transplant alpha-fetoprotein blood level. It is considered that if the alpha-fetoprotein is more than 400, that tumor has a bad prognosis and recurrence rate is high if after resection or even after liver transplantation. Gender is important. Underlying liver disease, whether the liver is cirrhotic or not, and what kind of cirrhosis we have, and stage of the tumor. And presence or absence of circulatory alpha-fetoprotein RNA, which is again, if it's present, that's a bad sign. And also there are a lot of new markers that is under evaluation, and hopefully we do see them in near future. So how to treat these patients? Treatment strategies are resection, some local regional therapy. We talk about it a little more in depth, and then transplantation and medical therapy. For resection, there should not be any vascular invasion, preserved liver function, and probably with single or maybe two hepatocellular carcinoma, which gives us opportunity to resect based on the severity of liver disease. And the patient is not a transplant candidate because of a variety of issues. Really, comorbid diseases are more important than advanced age. We do transplant patients with hepatocellular carcinoma if they fulfill criteria, even if they are in 70s. But comorbid disease like heart failure, cardiac issues, pulmonary issues become a little more risky to transplant these patients because of the poor outcome. And then these patients probably are not a candidate for local regional therapy when we don't want to do resection. Local regional therapy like radiofrequency ablation or the transarterial chemoembolization, percutaneous ethanol injection, or radiation therapy, these are all can be used as a bridge to transplantation or downstaging of tumor. And also when we shrink these tumors and watch these patients over time, if the tumor comes back rapidly, that is significant because that tumor is one of those with bad behavior and high risk for recurrence after resection or transplantation. But if their rate of growth is very slow, that's called good behavior and good risk for any surgical therapy. For transplantation, we do look at underlying cirrhosis. If the patient is cirrhotic, then that also can help. We do treat cirrhosis and cancer at the same time. Sometimes this is also, we do transplant patients with multifocal HCC. We'll talk about it again. These are patients that follow certain criteria, which most common one is Milan criteria, up that either one lesion less than 5 centimeter or 3 lesions each less than 3 centimeter are candidates for liver transplantation if there is no vascular invasion or no other comorbid condition. Of course, after Milan criteria, many other centers looked at different criteria. Probably most common one, in addition to Milan criteria, is San Francisco criteria. But United Network for Organ Sharing just accepts, Milan criteria as a factor of acceptability for liver transplantation and giving the patient opportunity to have a higher score on the list for transplantation. And then when we look at the other options, when all these fail, we have to look at medical therapy. There have been some advances in chemotherapy. There are newer drugs coming off the pipeline, and like sorafenib has been in use for many years right now, and then based on the effectivity of sorafenib, there are other anti-angiogenesis factor drugs that are in the pipeline, that they are coming out and they are being tested in hepatocellular carcinoma patients. So we talked about resectability rate, which is low. It's about probably 18 to 20%, and this is based on a large study done in Japan many years ago. And if there are other contraindications for liver resection, like presence of metastasis or invasion of the vasculature of the liver, and so on. So when we want to resect the tumor in hepatocellular carcinoma, first of all, even if they are cirrhotic, that is not a contraindication for resection if the patient is in child a category of cirrhosis. That means all the liver chemistry, like all the parameters of liver function, like INR, like bilirubin, they are all in good shape and they are normal, and we consider this patient child's age. There is no ascites, and also for resection, there should not be any, being a resection candidate, there should not be much of portal hypertension. Platelet counts should be more than 100,000, which again is a sign that hypersplenism is not there, and probably there is not much of a portal hypertension. There should not be a splenomegaly, which is again sign of portal hypertension. You shouldn't see any varices and normal INR and prothrombin time. So in this condition, you can still do major resection like taking a lobe out. However, there is risk with it. So we have to be careful about how we test these patients and check on the condition of the liver and amount of liver that we leave behind as a functional liver residue to see how much we can leave behind to support liver function and patients' need for staying healthy and staying not having a risk for going to liver failure. In more advanced cirrhotic patients with portal hypertension, there may be limited resection, like wedge resection, like we just take a piece of liver out, could be feasible, but again is guarded. And these patients probably, if they fulfill other criteria, they better be served with liver transplantation. But in non-cirrhotic patients, resection is feasible, but we need to be aware of the functional liver remnants. We can't go in and take three right lobe and segments from left lobe out and leave a left lateral segment. But if the left lateral segment is large enough to support the patient's life. However, these days we also do a portal vein embolization, and the rationale for this is that the side of the tumor, we embolize portal vein, so we pretty much redirect portal flow to the remaining part of the liver, which is a healthy part, and this portal flow has growth factors, and these can potentially increase liver size of the remaining part, so we can get a better outcome of the procedure. Then we talked about ablation therapy or local regional therapy, if you will. These are different categories: chemically mediated ablation, which we call which ethanol injection. This in the United States we don't do it much anymore, but in many countries they still use ethanol injection for a smaller tumor, and that can pretty much kill the hepatocytes. Hepatocellular carcinoma cells, and it's sometimes if the tumor is, let's say, less than 3 centimeter or 2 centimeter, you pretty much with multiple injection can get rid of the tumor as a curative. However, if the patient is cirrhotic, there is a chance that the patient develops other lesions in other parts of the liver. Then we use energy-mediated ablations, which cryoablation, we freeze the tumor, microwave ablation, and radiofrequency ablation, which cryoablation has certain side effects that, again, is not being used in the United States much, but we do use radiofrequency ablation to put a radiofrequency probe inside in the middle of the tumor. This can be done in radiology department under sedation or local anesthesia, or in the operating room when we have multiple, when we are doing laparoscopic evaluation of these lesions. And so we can use radiofrequency ablation. Again, it's very good for smaller tumors that can kill all the tumor cells and leave a big hole in that area that is indicative of necrosis of all the tumor cells. However, some larger tumors need multiple attempts. Then we also have another way of ablating tumors by interrupting blood supply to the tumor, and also intraarterial radiation therapy, which transarterial chemoembolization or TACE and transarterial radioembolization. We also not only directly attacking the tumor, but attacking, occluding blood supply to the tumor when we inject chemotherapeutic agents or radiation beads into the tumor site, and then blocking the arterial supply to the tumor. And this is pretty much based on our knowledge about when there's a normal liver and the tumor has started to grow. As tumor in early stages, we have portal flow, and hepatic artery portal flow gradually diminishes as the tumor grows further, and arterial flow gradually increase. So in larger tumors, like 2-3 centimeter and more advanced cases, pretty much we have all the blood supply from the hepatic artery and not much from the portal vein. So this is rationale for TACE and transarterial radioembolization, that we pretty much block arterial supply to the tumor, and this is very effective to cause tumor lysis and necrosis. Some of these patients, after TACE, when we take them to the operating room for liver resection or liver transplant, we don't see any viable tumor left in the liver, and that's indicative that TACE has been working really well by just blocking the arterial supply and giving some chemotherapy and radiation therapy at the same time to the patient. So now, rationale for liver transplant, on the other hand, for hepatocellular carcinoma is that 70 to 90% of HCCs are associated with cirrhosis, so we pretty much treat cirrhosis at the same time that we take the tumor out. And these patients have poor hepatic reserve to tolerate resection, so but by taking the tumor liver out and putting the new liver in, we pretty much use transplantation is more effective. And at the same time, even if we see a small tumor, about 20 to 60%, radiologically rather, about 20 to 60% of these small HCCs are multifocal. So when we take the liver out, we do see some other smaller lesions that were not detected by radiologic studies. This this percent increases as the tumor size increases. Like for example, if the hepatocellular carcinoma is less than 5 centimeter, about 40% of these explanted livers are multifocal, and if the tumor is more than 5 centimeter, almost 80% there is a chance of multifocality. So this is another important parameter, that not only we treat the tumor, we also treat cirrhosis. And this fact shows that we often underestimate the size and number of tumors by current imaging studies. Now, recurrence rate after resection is high, about 50 to 90% in 5 years. However, we still do resect some of these tumors if the liver condition of the liver permits us to do it, because we don't have that many livers available to across the board transplant everybody. The bad side of it, of course, is that with liver transplantation, we can get 5-year survival of almost 70-75% if they follow Milan criteria or the criteria for transplantation. However, if we do resect these tumors and we face a recurrence, and then we want to do salvage liver transplant, the survival of these patients, in 5 years, is about 40% or 45%. So the recurrence rate in the salvage transplantation is always higher than primary transplant. And as I mentioned, liver transplant treats both cirrhosis and cancer. Now, as we talked about size of the tumor, which is important in making in decision making for transplantation. This study was done back in 1995 by Dr. Selby at the University of Pittsburgh, and they noticed that patients with tumor stage 1 and 2, means less than 2 and less than 5 centimeter, at 5 years, probably around 70% of them are alive without any problem. But as tumor stage increases, we do see a drop in survival. The same criteria was checked by Dr. Mazzaferro in Italy, which was published in New England Journal of Medicine in 1996, the tumor, and they called it Milan criteria, a tumor less than 5 centimeter, as we talked before, or up to 3 tumors, each less than 3 centimeters, in the absence of macroscopic vascular invasion and no extrahepatic spread. These patients do survive about 70% at 5 years. And based on these results, Milan criteria have been incorporated as a modifying factor in model for end-stage liver disease, or MELD score, that we use these days for giving score to patients for transplant, and has been in UNOS has been using this for organ allocation. And this is the survival graph of these patients with less than 3 centimeter and 3 to 5 centimeter. They survive a lot better than larger tumors. Now, so if we want to put everything in one table, the best table that is present is Barcelona Liver Clinic staging for HCC. They have categorized these patients as very low stage, intermediate, and high stage, and based on this criteria, they make decision about treatment of these patients. So if a patient is Child-Pugh score A, good functional status, very early stage, and single tumor less than 2 centimeter, or early stage tumors, 3 nodules less than 3 centimeter each. If there is a single tumor, there is no portal hypertension, and everything is, liver function is normal, they do go for resection. But if there is portal hypertension, then in the absence of associated disease, as we discussed, like cardiovascular and pulmonary conditions or neurologic issues, they do go for liver transplantation. But if there is an associated disease that they cannot go through the process of liver transplantation and procedure, they do get ablation therapy with radiofrequency ablation, percutaneous ethanol injection, or they also, which can, as we discussed, they can cover smaller tumors, but the tumor is probably bigger. Actually, as mentioned, is Milan criteria. So we do have resection and RFA and transplantation in this group of patients. Now, if the tumor is more advanced and or liver disease is more advanced, then we can do TACE or transarterial chemoembolization in these patients. Some of these bigger tumors after TACE do regress and go back to very small tumor size, or they just disappear with a good response to TACE. Some of these patients, we call it downstaging. So these patients can potentially become a transplant candidate. However, most of these patients are not a candidate for transplant, and we have to just support them with TACE or radioembolization or things like that. And so this is how we do TACE or radioembolization. We put the catheter in the hepatic artery, branch to the tumor, and inject either chemotherapeutic agents or microspheres containing radiation for radiation therapy, and then we block this artery. So these agents will stay there, and in addition to ischemia, by blocking the artery, they work. There's a less chance of being washed out from the tumor area, so they stay there longer. There is a longer exposure to chemotherapy or TACE or radiation, and these patients do tumors respond pretty good. If the patient is in advanced stages, then we have to use some of these newer biochemicals or chemotherapeutic agents. And if the tumor is too far advanced, or the patient is Child-Pugh score C and very advanced tumor, we need to support these patients. So if we want to wrap it up, second most common cause of cancer-related death worldwide, and there is paucity of effective systemic therapies. Local-regional therapy is evolving, good to bridge to transplant, can also prolong survival in non-transplant candidates, but mostly they are not curative. Surgical approaches remain mainstay of therapy. Liver transplantation can offer long-term survival similar to non-HCC patients, and also these days we are extensively working to learn more about tumor biology, biomolecular markers for early diagnosis of tumor, and based on the tumor biology, we also use more of a tumor-directed therapies and to get better response of chemotherapeutic agents and so on. So this is again the same schema of how to stepwise manage this patient, which we already discussed. Now, the second tumor, which is a variant of hepatocellular carcinoma, is called fibrolamellar carcinoma. Is a little better prognosis, has a better prognosis than hepatocellular carcinoma. However, it can happen in non-cirrhotic patients, but by the time we see these tumors, because the patient has no cirrhosis, never had any problem with liver, most of these patients, we see them in really advanced stages. It's approximately 1% of all HCC patients. Sometimes some reports up to 10%, predominantly in younger patients, 10 to 35, and Caucasians mainly, mostly. Women are slightly affected more than male, and there is no history of chronic liver disease as we discussed, and very indolent course, and we usually diagnose them very late. And usually present with a palpable mass in the right upper quadrant area. When you examine these patients, sometimes mostly more than 10 centimeter in 70% of the patients, and which is very big mass of cancer with a small in a non-cirrhotic liver. So usually these patients present with non-specific abdominal discomfort. There is a palpable abdominal mass in good fair number of these patients, or there is hepatomegaly. Rarely they present with jaundice or inferior vena cava obstruction, depending on the location of the tumor and if they affect the bile duct system or compress the inferior vena cava. But these are very rare presentations. Imaging studies typically show a solitary big mass in the liver. A fair number of these patients at presentation may have lymph nodes in the portal hepatis area, and when they present, and approximately 50% of these patients eventually develop distant metastasis. Liver function test in late stages is sometimes abnormal, but in the early stages may not be abnormal. And one other characteristic is that less than 10%, unlike HCC, which is more than about 80%, these tumors of less than 10% show increase in alpha fetoprotein, and that hardly ever goes above 200. So these tumors are they secrete less alpha fetoprotein. And treatment, the key to successful management of the fibrolamellar carcinoma is early diagnosis, followed by complete surgical resection, and with the 5-year survival of 50 to 70%. And of course, depending on the stage of the disease and how we, at the time of resection, there is a very high chance for tumor recurrence. Transplantation is another effective method of treating these patients if the tumor is not resectable, and with a 1, 3, 5, and 10-year survival of 90, 75, 50, and 25%. And again, in transplant, recurrence rate is affected by the stage of the primary tumor at the time of transplantation. Of course, if these tumors appear in a cirrhotic patient, then the prognosis is a lot worse. So, changing gear a little bit, and discussion, we focus on cholangiocarcinoma, which is the second most common primary hepatic malignancy. 90% of them are adenocarcinoma, and the highest incidence is Southeast Asia, patients with hepatitis B, parasitic infection, or also exposure to toxins. 5,000 cases per year we see in the United States, and usually is very uncommon in patients with age less than 50, unless patients with specific primary disease like primary sclerosing cholangitis, that we do see cholangiocarcinoma in younger age as part of the disease process. And usually they present with jaundice, vague right upper quadrant pain, pruritus, anorexia, weight loss, and all the elements of cancer. The cholangiocarcinoma is divided between 3 categories of extrahepatic, hilar, and intrahepatic. And by this, I mean intrahepatic ones are in the periphery of the biliary system, and they are not as common as other two. The 5 to 10% of cases are intrahepatic. Hilar or perihilar cholangiocarcinoma is the most common, 40 to 60%, and these are all above or more distal to this junction of cystic duct and common bile duct. So common hepatic duct and branches. This is the perihilar area or hilar area that these tumors happen in this area. They used to carry the name of Klatskin tumor, but this nomenclature is not being used anymore. And then we have extrahepatic bile duct with a chance of 20 to 40% chance of having cholangiocarcinoma in this part all the way to the head of the pancreas. So the risk factors for the tumor, as with the primary sclerosing cholangitis, about 7 to 13% of patients with primary sclerosing cholangitis they develop cholangiocarcinoma, and that's why with these patients we have to watch them very carefully with serial imaging, ERCP, and brushing of if they have a stricture in the common bile duct, continue to do brushing and also testing for cytology. Patients with choledochal cyst, Corolli's disease, they have higher incidence of cholangiocarcinoma. Liver fluke infection in Southeast Asia, biliary enteric drainage may increase risk of cholangiocarcinoma. Hepatolithiasis, cirrhotic patients do have increased risk of developing cholangiocarcinoma, but that's not as much as hepatocellular carcinoma. Again, any kind of inflammatory response of inflammatory condition of the liver, like infection with hepatitis B and C, can potentially increase risk of cholangiocarcinoma. And this is a very common major risk factor, thorostat exposure, which thorostat can increase risk of cancer in different kinds of cancer, but cholangiocarcinoma also is another common cancer. So how we diagnose it? With imaging, again, triphasic CT scan, hypodense lesion with irregular infiltrative margin. We usually see biliary dilation. Sometimes we do see vascular invasion involvement when the tumor is in the hilum and hepatic artery and portal vein branches are entering the liver in a very close space, so chances of involvement of hepatic artery or its branches and portal vein is has increased because of vascular involvement. Sometimes because of the vascular involvement and also lower bile duct obstruction because of the tumor, we do see lobar atrophy. And also we do see metastatic disease in regional nodes, peritoneum, lungs, and other places. And again, for resection of these tumor, because mostly are not cirrhotic, because we usually have to do a wide excision with at least a removal of a lobe if needed. So we have to be careful about functional liver residue in the other side. And as we discussed, maybe portal vein embolization can be also effective in this situation as well. MRCP can better characterize biliary stricture and is non-invasive. PET scan can show presence of hepatocellular carcinoma, and ERCP and EUS with brushing, again, is another way of evaluation of the patient for diagnosis. And when we do brushing and get samples of the dominant strictures in the bile duct or high in the hilum, we do fluorescent in situ hybridization or FISH, which is very sensitive to diagnose malignant cells. And of course, some tumor markers like CA19-9 is very important to check if it's has a very high sensitivity and specificity, especially if we see it in hundreds and sometimes over 1,000. Of course, we have to also be careful that CA19-9 can go up in inflammatory diseases of the biliary system, even with obstructive jaundice because of stones or other just benign strictures in the PSC patients, or sometimes in some autoimmune diseases in the hilum of the liver, like autoimmune disease of the biliary system. Bilirubin can go up, and also alkaline phosphatase and GGT can go up, and also AST and ALT. So liver function is important to also look at, but main tumor marker is CA19-9. So when we do MRI or CT scan, we do see a infiltrative lesion in the hilum with dilated biliary system, or even a very small lesion in the hilum or perihilar area with dilated biliary system. is. And also in peripheral cholangio, we do see diffuse mass in the periphery of the liver, not close to the hilum. And of course, ERCP, you can just do the ERCP and the stent bile ducts if the tumor has not completely occluded the bile ducts, biliary system. And with the stenting, we can get rid of jaundice, and is a kind of palliative treatment for these patients at least to decrease jaundice. And of course, ERCP also is very important procedure for making diagnosis of hepatocellular carcinoma. So, intrahepatic cholangiocarcinoma usually is mass in the form of mass forming, or in the form of involvement of the bile duct. A tumor grows inside the bile duct, or a tumor occludes bile duct by encasing the biliary system. Either one, it doesn't have a good prognosis, because again, we do see these patients, because the biliary system is open, we probably see jaundice very late in the disease, and also we do not see very highly abnormal liver function test. There may be some 1 or 2 bile ducts obstructed and dilated. So if we are concerned and we are suspicious to hepatocellular cholangiocarcinoma in the periphery, we do CT scan or MRI to see it. And there are variety of pathological condition, or that we don't want to go through them all because of the timing. But what is important in the hilar cholangiocarcinoma, as you can see, is start with a junction of cystic duct and common bile duct. It could just involve the common hepatic duct and cystic duct origin, which is type 1. Type 2, this tumor has grown into the right and left duct. These are resectable because we can go up here or go up here and cut these bile ducts and take the tumor out, and drain the remaining part of the biliary system to a loop of jejunum as a Roux-en-Y procedure. However, when it grows in predominantly to one duct or the other one, then we have to add lobectomy to the procedure and use to connect the bile duct of the other the remaining lobe to the Roux limb of jejunum for the biliary drainage. However, when we have extensive extension of tumor to the secondary radicals of the bile ducts or multifocal cholangio, then these are not operable, and they are not resectable and operable. For treatment, really resection, when we do resect these tumors and we don't leave any positive margin, a 5-year survival of about 40% is there, but there is no, if you leave a positive margin, there is no 5-year survival. And so now, more recently, just like hepatocellular carcinoma, liver transplantation has become an indication for very selective group of patients with cholangiocarcinoma. And Mayo Clinic started a protocol doing transplanting these patients with cholangiocarcinoma, and but they had a very restrict protocol. It should not be resectable. It's sitting right in the hilum of the liver with involvement of right and left duct probably, and tumor should be less than 3 centimeter and cholangiocarcinoma mostly arising from condition of primary sclerosing cholangitis. So we have to change the liver. So we do transplant in these patients, but there are exclusion criteria. There should not be any previous attempt for resection, because that violates the tumor plane, and then there is a risk of tumor spread. There should not be a transperitoneal biopsy of the tumor. If we want to biopsy the tumor, we should go from inside the bile duct through ERCP via ERCP and go directly to the tumor site and get a brushing of the tumor. Otherwise, any biopsy from outside, even through let's say endoscopic ultrasound and finding the tumor and passing a needle from outside, can make these patients not a candidate for transplantation. If there is intrahepatic metastasis or evidence of extrahepatic metastasis, again, these are exclusion criteria, and any kind of abdominal irradiation, presence of infection or other malignancies within 5 years. These are not a candidate for transplantation. And the preparation for transplant also is very important. We do see these patients. They follow all the inclusion criteria. Then we give them external beam radiation, intraluminal brachytherapy by placing a PTHC in the catheter percutaneously and going to the tumor site and giving internal intraluminal brachytherapy. We do give 5-FU to these patients until we do a staging surgery, and the staging surgery is the part that we go in, check on all the lymph nodes, be sure that there is no extrahepatic malignancy, and then this staging laparotomy is done, and then we keep these patients on oral chemotherapy until we have a liver available for these patients. And this has become an indication for transplant, and UNOS has approved this criteria. Transplant outcome is relatively good. If you remember, liver those with resection, they had less than 40% chance of 5-year survival, and very limited number of these patients. Here we have 90% 1 year and almost 60% 5-year survival. And of course, not all these patients through the protocol can get a transplant, because there will be several steps that we pass these patients through those steps, and there will be there's a dropout based on appearance of new lesions or intraperitoneal lymph node involvement or distant metastasis. So these patients may drop out of the list and not becoming a candidate for transplant. So how about intrahepatic cholangiocarcinoma? If they are resectable, we do resect them, but if they are not resectable, there are new work we do see when they transplanted patients with very early stage of intrahepatic cholangiocarcinoma, means less than 2 centimeter lesion, intrahepatic cholangiocarcinoma, and when they looked at 48 patients, those who had followed this criteria, 15 of 48, they lived pretty long. The recurrence rate was 18% in 5 years, and survival was over 65% in 5 years, which is pretty good. But those patients who had more advanced disease, 33 of 48, they had more recurrence and less survival, which was significant. So this concluded that maybe patients with early stage of intrahepatic cholangiocarcinoma also may become a candidate for transplantation. Of course, this is not a UNOS approved indication, but if we get more and more data and we see a good outcome, so we can repeat this good outcome, then they could become a candidate for transplantation. Also, another group in Texas, they did extensive chemotherapy. They gave these patients neoadjuvant therapy to patients with intrahepatic cholangiocarcinoma. 12 patients showed no disease recurrence, no disease progression on chemotherapy, and out of these patients, 6 received liver transplant, and overall survival was 83% in 5 years, which is pretty good for intrahepatic cholangiocarcinoma, and disease recurrence-free survival at 5 years was 50%, which is again good. But they should really show improvement and no progression while they are on chemotherapy. So again, select patients with intrahepatic cholangiocarcinoma could become a candidate for transplant if they show a good response to therapy. Hepatic epithelioid hemangioendothelioma is another category of tumors, primary tumors of the liver. This by itself could be categorized as part of sarcomas, but the behavior of this tumor is different than most of sarcomas. They are very low, slow-growing tumors, and we do transplant patients with when they are not resectable. Rare malignant neoplasm from vascular endothelium, predominantly in female population, unpredictable prognosis depending on the tumor behavior. It could be very slow, but also we do see some fast-growing tumors, which is more in nature of sarcomatous nature of the problem. Usually they are multifocal, and most of the time are misdiagnosed as metastatic lesion, but again we have to have high suspicion to think about hemangioendothelioma and treat these patients in that regard. Appears in the background of normal liver histology, and sometimes they are resectable, so we do resect them. But if they are not resectable, which more than 90% of patients are unresectable, transplantation is an option with excellent 5-year and 10-year survival. 5-year survival of these patients is almost 70%, which is just like hepatocellular carcinoma, and these about more than 60% are disease-free survival. Even when the tumor comes back, either in the liver or other parts of the body, they are extremely slow-growing, and that's why this has become an indication for transplantation. And actually, when the tumor is back, let's say in the liver, you can do radiofrequency ablation and kill the tumor, and these patients survive a long, long time. Even at the time of transplant, if we have involvement of hilar nodes or vascular invasion, these do not preclude patients from getting a liver transplant. Even in the presence of lung lesion, we can transplant this patient and then go ahead and treat the lung lesion. So this is a very slow-growing tumor, and transplantation is indicated for the tumor. Other primary tumor of the liver is hepatoblastoma. Unlike all the tumors that we discussed, this is a tumor of very earliest ages of life, which happens in mostly happens in less than 3 years of age, and usually presents with upper abdominal mass, and is associated with several syndromes that pediatric patients may present, and diagnosis is based on CT scan or MRI. These tumors show very high alpha-fetoprotein, sometimes in tens of thousands, and when you treat these tumors with chemotherapy, you see a dramatic response with drop in alpha-fetoprotein in these treated tumor. And of course, we can biopsy these patients and get the diagnosis. Usually happens in the right lobe, well circumscribed, 5 to 20 centimeter in diameter. Histology is immature liver cells, fetal or embryonal, epithelial cells or mixed type, and mesenchymal type, which aggressive tumors invade locally, spread locally to the local lymph nodes, or metastasize to lung, adrenal, brain, and bone marrow. But most of the time, if the tumor is localized and in the liver, or some extrahepatic extension, these patients do respond to chemotherapy mostly, and that's the basis of how to treat these patients. Usually, if the tumor is in one lobe or segment, stage 1, and left medial segment, that is a stage 2. If we have three of these segments involved, which we call it stage 3, and then stage 4 when all parts of the liver are involved. And so treatment for cure we have to completely resect the tumor, and they have excellent chance of survival of 5 years of 70%, and if tumor is completely resected, almost 90% of these patients survive 5 years, and that's pretty much cure. And transplantation can be an option also in these unresectable tumors, then when we cannot resect the tumor, but as long as possible, if we resect the tumor, that can save the patient from transplantation. And sometimes an unresectable tumor can become resectable by extensive chemotherapy when the tumor shrinks, and we can have a good residual leave a good residual volume of liver after resection. We do resect these tumors. However, one problem with the patients that they are resected and they have recurrence, survival of these patients after transplantation is not as good as primary transplant for the tumor. However, as we see, if they are resectable, we would rather resect the tumor. Patient will not need to go on immunosuppression and long-term complications of transplantation and so on. Last group of primary lesions of the liver are sarcomas. These are highly malignant tumors, mostly angiosarcoma, and is the most common primary sarcoma of the liver. Torostat exposure, vinyl chloride or arsenical compounds, they can induce hemangiosarcoma, development of hemangiosarcoma, and the peak incidence is old age group. Male predominance 3:1, and there are other kinds of sarcoma like embryonal sarcoma, which is the third most common hepatic cancer after hepatoblastoma and hepatocellular carcinoma in children. And peak incidence happens between 6 and 10 years. And then we discussed about epithelioid hemangioendothelioma in our few slides before. Then other primary hepatic sarcomas are fibrosarcoma, leiomyosarcoma, liposarcoma, hepatobiliary rhabdomyosarcoma, which is all of them are pretty rare tumors, but when involvement of the liver is too extensive, and these patients do not respond to transplantation. All patients with that were transplanted in the past for these tumors had recurrence of the disease and loss of patient in less than 2 years. Now what are the secondary malignancies of the liver? As we talked about it before, these are actually the most common malignant tumors of the liver when we consider all malignant lesions. So when we see a lesion in the liver which is malignant, we have to think of secondary and then hepatocellular carcinoma and rest of the tumors that we already discussed. Metastatic hepatic tumors are most common hepatic malignancies. 95% of hepatic neoplasms at autopsy are metastatic tumors. Most common sites are colon, lung, breast, and pancreas. And also malignancies arising in organs drained by the portal vein are more likely to show hepatic metastasis and are more likely to have metastasis confined to the liver, which is a benefit of having metastasis from colorectal and intestine cancer, which we'll talk about it, how to treat patients with colorectal metastasis in a few minutes. So, what are more common metastatic tumors? Neuroendocrine tumors are not very common lesions, but they do metastasize to the liver, and These tumors are a heterogeneous group of tumors originating from various locations like pancreas, GI tract, lungs, and we see them as insulinoma, VIPoma, gastrinoma, carcinoid tumor, which is more common ones, and then glaucogonoma and somatostatinoma. So there are a lot of tumors that can come out in the intestine or around the pancreas and metastasize to the liver. And usually they are diagnosed when they are advanced, and most of the time 40 to 80% with metastasis at diagnosis. 75% of small bowel neuroendocrine tumors and 85% of pancreatic tumors present either synchronous or metachronous metastasis with the liver and as their initial presentation. And with having said that, 5 to 10% of liver metastatic neuroendocrine tumors, we cannot find a primary source for them despite doing extensive workup. So 5 to 10% of these tumors, we can never find the primary, and they could be primarily from the liver itself, but anyway. 5-year survival for patients with neuroendocrine tumor is pretty good actually. 75 to 100%, but it comes down to almost 50% when liver is involved and we don't treat the hepatic part of it. So these are very slow growing tumor, and that is also makes a debate whether these patients need resection or transplantation or just watching them. Most of these patients, when you do extensive debulking procedure, they survive as good as if you give them a liver transplant. And but because the involvement is diffused throughout the liver, only 10 to 20% of patients with liver involvement are candidates for resection, and 5 to 10 year survival after resection could be as high as 86% and 80% at 10 years. So it is pretty good survival, if you will. Now, when we do transplant for neuroendocrine tumor, metastasis is for a very limited criteria. They should be unresectable and well differentiated. And as I mentioned before, 5-year survival outcomes are comparable to resection when we transplant these patients. So many centers, if the tumor is resectable, they avoid transplantation because they do get the same survival, and there's no reason to use a liver in these patients and put these patients on immunosuppressive therapy for life. And when we talk about the tumor itself is rare disease, as we mentioned before. Liver is most common site for GI neuroendocrine tumor metastasis after lymph nodes, and carcinoids are non-carcinoids. These are most of the neuroendocrine tumors, and carcinoids are more common than the whole rest of the list that we discussed. And these tumors are either functional or non-functional, well differentiated or poorly differentiated, and they have a very indolent course, as we discussed. So this is a single lesion of the liver with neuroendocrine tumor, but this is the more common picture of these tumors that we see, and this makes it really unresectable tumor, and we can see in these PET scans that liver is involved as well as the pancreatic area. So the pancreas is involved with the tumor, and at the same time there is synchronous metastasis to the liver. So presence of liver mets is most significant factor affecting the outcome, because as we showed, the outcome comes down if with unresected neuroendocrine liver mets, 5-year survival is 30% and 90% without mets. So if we don't have liver involvement, 90% of these patients can survive 5 years, but liver involvement decreases survival if we don't do anything else for the liver, like resection or transplant. Mainstay of therapy is resection or cytoreduction therapy, because most of the time we cannot resect all the tumors. And really there is no difference if we do complete resection with zero margin or even more positive margin, or we leave some tumors behind, because overall survival is 75% at 4 years if we can debulk and do cytoreduction therapy. So when we do transplant in these patients, overall survival at 5 years is 90%, and disease-free survival is 77%. But just like hepatic endothelioma, these lesions that appear, you can easily treat them with RFA, or go in and take them out, or if they appear in lungs, you can just resect them in the lung. So really overall survival is good in these patients. And post-transplant survival is poorer in older patients more than 55. Or definitely these patients have higher risk for recurrence, and also risk is higher if the patient has very high mitotic or tumor activity. More than 5% is considered as high risk, but if the tumor is less than 2% mitotic activity, or we call this Ki-67, these tumors behave lots better. And if the patient with duodenopancreatic and large tumor burden of liver, they do have poorer prognosis than smaller tumor burden of the liver. But there should be at least 6 months follow-up after resection of primary tumor, and we like if it's in pancreas or anywhere, and we see a stability of the patient before we consider doing liver transplant in these patients. And patients with primary from stomach, pancreas, and intestine and liver mets are better candidates, as we discussed. Now, colorectal cancer metastasizing to the liver is another large category. We do see a lot of patients with colorectal cancer with metastasis to the liver. Colorectal cancer is the third most common cancer worldwide, and second most frequent cause of death of malignancy in the Western societies. About 600,000 deaths happened worldwide in 2012, and 50% of the patients will develop metastasis. 25% already have metastasis as synchronous at the time of diagnosis of primary, and 30% will develop metastasis during the course. And only 10 to 20% of patients with liver metastasis are resectable. This is the main issue, that most of them are not resectable, and 5-year survival post-resection can go up to 25 to 55%, and 5-year survival of non-resectable is less than probably 10%. Treatment options that we have for these patients: resection of liver metastasis at the time of resection of primary tumor, which is that some group, they do this, they resect the primary tumor and do take care of the metastatic lesion, synchronous metastatic lesion. But some group prefer to remove the primary tumor and do stage resection of the liver metastasis. And if some patients, some group also, they do resect the tumor in the liver and then put the patient on extensive chemotherapy and then go and remove the primary tumor. But again, systemic chemotherapy is only for unresectable tumor burden. Intraarterial chemotherapy via a pump in hepatic artery has become more and more popular. They put a pump in the subcutaneous area, and this pump continuously injects chemotherapeutic agents to the liver, and we follow these patients for the tumor size, and if the tumor is reducing in size or increasing in size. Portal vein embolization to increase the size of a liver remnant as part of the stage resection is also important, as we discussed before. If tumor is mostly in the left lateral segment of the liver is free of tumor, and we want to take out chunk of liver, we can embolize the right portal vein and let the left lateral segment grow, and the patient tolerates resection. And then last but not least, liver transplantation. There's a controversial issue about transplantation, especially in the era of organ shortage. Of course, most of the experience goes back to early 80s and 90s when these patients did not do well after transplantation. However, recently in a group from Stockholm, the 21 patients under very strict protocol and transplanted these patients with a 5-year survival of almost 60%. Of course, most of these tumors came back, but these patients stayed alive for 60% of these patients stayed alive for more than 5 years, and the more later data from the group shows 10% survival over 35%, which is pretty good in patients that if we don't do anything for them and they are not resectable, they all die in less than 2 years. So and when we look at overall 5-year survival compared to chemotherapy, 56% versus 9%. And this is pretty good achievement if when we do liver transplant. However, we have to follow very strict rules in these patients. CEA should be at the time of transplant, before transplant should be less than 80. Maximum tumor diameter in the liver should be less than 5.5 centimeter. And liver transplant to be done at least 2 years after resection of the primary. Some group they have decreased it to 1 year. However, this is a must. Primary has to be removed, and we follow the nature of the tumor and then to consider liver transplantation, and especially these stable disease or partial response to chemotherapy before transplantation. And so based on that, we can see this good survival of these patients, about 60% at 5 years after liver transplantation. So there are other groups also considering looking into the transplanting these patients. However, as we know, organ shortage is the main issue in transplanting colorectal metastasis, because we have many colorectal cancer patients that they do metastasize to the liver and they want to have a transplant, but this doesn't work unless we do use a living donor liver transplant in these patients. So we have other metastatic lesions to the liver: lung, breast, prostate, melanomas, lymphomas, and all these. This is a case of melanoma metastasizing to the liver that killed the patient very quickly. So, in conclusion, hepatic malignant lesions, we have better understanding of tumor biology these days. We know how they grow, and we have tumor markers, and we know that we have learned better response of these patients with tumors to chemotherapeutic agents or radiation therapy that we have, better diagnostic modalities we have, so we diagnose these tumors in a lot earlier stages, and we have advanced surgical options, and also advanced ablation therapies, and liver transplantation has become a viable treatment option for these patients.